Jess? Joe, do you want to share your screen now? So we've got the opening title up, please. There we go. We'll just give it one more minute before we start, everyone. Bear with us. All right, what time we got? A couple more seconds just to make sure everybody can log on and listen to the start. Right, I think we'll make a start now just to make sure we give ourselves the opportunity to run to time. Good afternoon, everybody, and welcome to our last in the series of our palliative care webinars. The rest have been fantastically attended, so hopefully this one too. Just a quick housekeeping before we get going. We've got the chat function available if you want to talk to the team, if you've got any sound problems, and we've also got the Q&A if you want to pose any questions as we go along. We'll make sure we can have a few minutes at the end to answer any questions that you may have. We're all working from different locations, so bear with us if there's any technical problems, any interruptions. But I think that's enough from me. I'll hand over to our fantastic speaker this afternoon, Dr. Joe Hayes. Thank you.
Hi, good afternoon, everyone. Can people hear me? Give me a thumbs up, someone. Yeah, thank you. So welcome to the last of our webinars. I'm hoping that some of you who have joined us today have heard the previous ones, but there's a little bit of recapping on what we've learned previously. So just to remind you, these are free webinars put on by my Cardiff University, and on the slide there are my colleagues from the Cardiff University MSc programme in palliative medicine. Today we're just going to talk about supporting care home staff with end-of-life care, especially during the COVID pandemic. I'd be really grateful if you would try and interact as best you can. It's difficult on a big Zoom call, but there will be the Q&A button for questions towards the end, and you can put stuff onto the chat to ask us questions as we go, and there are some polls to fill in just to get a little bit of information about who we've got on the call. And please fill in your feedback, because that's the way that we can hopefully persuade our colleagues in Cardiff University to put on some more of these after the Christmas and New Year period. So thank you. So we're just going to talk about palliative and end-of-life care in nursing and residential homes. That's one of the nursing homes that I visit sometimes in my role as community palliative care consultant within the Vale of Glamorgan, and we have got some colleagues who are from that nursing home, so some of the senior nurses and managers there joining our call today. So I think it'd be really useful, first of all, if we could just get an idea of who we've got on the call. Jess or Charlotte, do you mind just launching the first poll for us? So for all those people who are out there, just let us know what your main role is. So GP or GP trainee, district nurse, ambulance service, palliative care team, pharmacist, allied healthcare professionals, nurses, or other.
Joe, just while the poll is setting on, and welcome everybody, I'm Fiona. There's a comment, just a question. Is it possible to make the slides any bigger? I'm not quite sure whether your setting on the computer you're using will enable that. So this might be as big as we can get them. But just wondering if there was a chance they could be a little bit bigger. I suspect it might be the setting.
Not
It's
that
not.
I can easily.
No, it's not a problem we've had before. But then I think you're on a different system. You might be on a different system.
Apologies, okay. I'm using a different computer, so I'm not quite sure how small they are. We are going to share all of the slides.
Great.
Are they unrealistically small? I'd have to swap computers, I think, otherwise.
Paula's just wondering whether there's a slideshow setting. So whether it's
display
settings.
Yeah.
Yes. Not obviously, I'm afraid. So Paula, thank you for raising the question. I think this might be as good as we can get it for the moment, but we will share the slides afterwards.
Unfortunately, Paula, I'm having to use a different computer from the previous webinars. Apologies, I may try and have go as we go along. So you can all see the poll there, can't you? So we've got 25% GPs or GP trainees, and a fair percentage of nurses there, some allied healthcare professionals, and a few people from the ambulance service. Okay, thank you very much. Could you just do the next poll for me, please, Jess? So it should be, what setting do you work in, for our next poll, if that's okay? Thank you. So are you mainly in the community? Are you mainly nursing homes, secondary care, specialist palliative care, or a mixture? That's fantastic. It looks like we've got sort of 48 or 50% mainly nursing home, and you are the people for whom this webinar is intended, so that's brilliant. And mainly community for the rest, no secondary care, which is interesting, because I imagine that it may have been useful to share some of this with our secondary care colleagues, but there we go. Okay, and could you just do the third poll for me, please, Jess and Charlotte? So are nursing homes your main place of work, or you go there often in your role, for example, as a GP or as a district nurse? Do you receive patients from or discharge them to nursing homes, or do you provide remote support? Thank you. So for 40% of you, it's your main place of work. So that's a really good audience from nursing homes. So thank you to everyone for joining. And hopefully all of those of you who don't work in nursing homes but go there occasionally will learn or share information about how we might best manage the patients who are there as part of this webinar. Thank you. Okay, we can close that, I think. So just recapping, where are all our palliative care patients cared for? That's a hospice where I am based. And often people think that that's where all the palliative care patients are, but of course they're not, because we've only got small numbers of beds and actually have not had all of those open during the COVID pandemic. And as palliative care specialists, we're actually seeing relatively small numbers of patients compared to all of those who are out there with palliative care needs. So where are all the palliative care patients? Well, some of them are in hospital. We would like to avoid lots of them being in hospital, because it's often not the best place for them. It's difficult to get into hospital. You may well be in one of those ambulances outside for a significant period of time, and that was more than 24 hours this weekend just gone. And you may well catch COVID at the moment, and you know it would be good to try and avoid hospital admissions at the minute, because health services are starting to struggle for all those people for whom they wouldn't benefit. Okay, so most palliative care patients are at home. There are lots of us on this call that manage palliative care patients in the community and in their own homes. And if you ask patients, that's where a vast majority of them would like to be, depending on at what point you ask. But we all know that that's not possible for lots of our patients, be it because they're frail, elderly, mobility difficulties, difficulties organising care, or don't have family around them able to support. There are a significant number of our palliative care patients, or patients who are towards the end of their life, who are based in nursing homes, and that's what we're going to talk about today. So who looks after patients when they're dying in the community or in nursing homes? So that's a picture of the team that I work with. Actually only the nursing and medical colleagues of our team, because we do also have allied healthcare professionals, physios, OTs and social work support. So are we looking after all of those palliative care patients in the community? So not really. As I said, we're only seeing small numbers of patients with specialist needs. So as I've told you before, most community palliative care is done by non-specialists. Families, friends, neighbours, GPs, of which 2/3 of the time it's out of hours, district nurses, community pharmacy, agency carers, the ambulance service and care home staff for all of those people who are based in nursing and residential homes. So where do people want to die? If you ask them when they're relatively fit and well, most people would like to be at home. They may change their mind if they don't have adequate support, and the proportion of people opting for hospice care rises the closer they get towards the end of their life. But hospice care is not possible for the vast majority of people. We've got small numbers of beds and they don't have particularly specialist needs. So for those people who are in nursing homes, that is their home. And if people are saying that they would want to remain in their own home, well, towards the end of their life, that often is a nursing or residential home. And people like me who work in the community very much see it as our role to try to facilitate patients staying in their own home and in a familiar environment where they would want to be, and supporting the staff who look after them there to help with things that they may not be familiar with, be it medicines, needs, equipment, and all of that. We've seen this bit of slide before as well about where people die. The black figure, the red figure and the blue figure span about 10 years there. There are less people dying in hospital, which is generally a good thing. And there's slightly more people dying at home, which we would like to see as a positive thing also. Small numbers in the hospice and elsewhere, and the care home numbers are increasing there. So there isn't a particular increase in care home beds, but I think that staff in care homes and patients in care homes are much more likely to stay there now towards the end of their life, and are less likely to be admitted for the last few days and weeks. And I think that's probably why that number's increasing, but it would be helpful if we could in future try to look at that in a bit more detail. Okay, how do we know when people are towards the end of their life? We've seen these trajectories before, where cancer, you often have a reasonably high level of function and then deteriorate in an almost straight line way when you're towards the end of your life. And with heart failure and COPD, there is a gradual decline, but that's interrupted by these sharp dips where you might have an exacerbation or a decompensation. Down here, the frail elderly and patients with dementia tend to have fairly low function, but they sort of bounce along the bottom there for quite a prolonged period of time often, and it's really difficult to try to predict exactly when they really are towards the end of their life and death is imminent. And these people over here are the majority of the population of patients who are in nursing homes. So those of you who work in nursing homes, it's actually quite difficult to predict among all the people that you've got who might be towards the end of their life. This is a slide that you've also seen before. Would you be surprised if people died within the next 6 months? It's a tool that we use to attempt to predict. And if you're unsure of that, you can look at the general clinical indicators, which are things like poor performance status, so not being able to be mobile, weight loss, unplanned admissions to hospital. And there I've highlighted that patients in a nursing home or NHS continuing care unit. So all of our nursing home population of patients probably need to be considered as to whether they've got specific palliative care needs and how we can address those and how we could try to plan for their future. So I'm just going to give you a patient to have a think about. This is Reg, he's 89 years old. He's been in a nursing home for the last year and a bit. He's got heart failure, dementia, prostate cancer, several hospital admissions for breathlessness and edema, which have been thought to be due to his cardiac failure over the last year. And the admissions have been partially helpful, but he hasn't really regained the place where he was before going in each time. and because of his cognitive impairment or dementia, tends to get quite distressed and disorientated in hospital. What's happened to him now is he's losing mobility, his communication's not so good, and he's got some difficulties swallowing. So today he's breathless, he's got a cough, he feels hot to touch and looks pretty poorly. And if you're one of our care home staff, you're actually quite worried about him today. So what are your thoughts and what will you do? And I would be really grateful if you could try and put some of that down on the chat function. So what are you thinking about and what do you think you'd like to do for Reg? So with my view on this screen, guys, I can't see the chat particularly well. So it would be good if somebody could let me know what's on there. I shall try and open it up now.
I can do that, Jo. So I've just put the question on, what are your thoughts, what will you do? So start writing, people. So we've got seek GP advice, address possible delirium, actually look and see if he's got a plan, make him comfortable, act on what his particular needs are, speak to relatives, does he have any advanced decisions that you know about, talk with GP and family on how to proceed, does he or doesn't he have capacity, can he be kept there, does he need to move, do we need to ring 999, just checking out the plan for end of life care. And we've got reversible causes, we're really getting in the swing now, this is really great. Thorough assessment to treat or rule out underlying causes for acute or chronic unwellness. Attempt to treat in the place, intervene based on advanced care wishes. Great collection of thoughts there.
Thank you. So I'm hoping as we go along, I'm going to try to cover most or all of that, but feel free to put stuff on the chat as we go, or to try to interject as we're talking about the relevant bits. Thank you very much, everyone, for your interactions. Okay. So I think we probably need some fairly urgent advice, don't we, about Reg? I think if you're staff in a nursing home, you're not necessarily expected to take all of these decisions on your own. It's really important that you ask advice, that you get the appropriate advice in a timely way, and we share some of the decision making here. But the staff who've been looking after Reg for the last 15 months are one of the most important people to try and be involved in this, because you will know, you and his family, depending on whether he has family who up until COVID might have been visiting regularly, you're going to be the best people to know him, know about his needs, know about any future care plans, and advocate for him as to what we think might be best. So we might well ask a GP advice for assessment. 999, I guess that's a consideration depending on how unwell he is or what advice you get from elsewhere. But I do know that we often would prefer to be avoiding calling 999 for situations like this. And for our ambulance service colleagues who are on the call, we would be very happy to come when appropriate, but I think would, very much appreciated if we considered whether 999 was appropriate in this situation as well. And there might be other people who know him well. It's possible that palliative care might be involved. It's possible that there are other healthcare professionals who know him. And he might have been, it might have been a different situation where he's new to the nursing home and you don't have 15 months worth of experience with him. And it might be that you'd be contacting the team who'd looked after him in hospital until very recently for just some guidance about where to go. So we've said that he's breathless, he's got a cough, he feels hot to touch. I think we might consider doing some obs, and I think that may well be helpful. And that would probably be helpful to do those as soon as possible so that you're armed with some more information when you contact one of your colleagues for advice. Okay. I don't know if anybody's thought about not only who you contact, but how you sort of structure that call to get the information across in sort of fairly clear and concise way, because the likelihood is that you're going to be talking to somebody who's never met him before, and you're going to have a short period of time to try and communicate. Okay. So I appreciate that that's probably not come up very big for you, but SVAR communication tool is something that can be really helpful to try and get information across. I think it's slightly bigger on the next slide. So hopefully you can read some of that, and we're going to share the slides if not. So S for situation. I'm Jo, I'm a nurse on first floor ward. I'm calling you about Reg. I'm calling because I'm really concerned that he's not well today. He's more breathless. He's got a high temperature, and his temperature is. I've done the rest of his observations, and they are. Just for some background, he's been here for 15 months. He's got heart failure and dementia. And, you could talk about some of the background that I've given you, that he's been in and out of hospital quite a lot. He sometimes has some benefit, but actually he doesn't get back to his previous function, and he tends to get quite disorientated and agitated when he's there. Okay, I think the problem is, and we haven't yet talked about what we think the problem is. What might the problem be for Reg? Would you like to just put some of your potential issues on the chat? And Fiona, do you mind just having a look what people are putting on there? So he's breathless, he's got a cough, he feels hot to touch and looks generally really unwell. What are you thinking? He's got a background of cardiac failure, dementia and prostate cancer.
So we've got chest infection, we've got sepsis, possible COVID, chest infections winning the poll at the moment, although there could be UTI, exacerbated COPD, COVID, possibly PE.
Okay, thank you.
Edema, yeah.
And it could be to do with his cardiac failure as well, although he's got a temperature, I guess that's against that. And we've also said he's got swallowing difficulties, haven't we? So it may be that he's aspirating and that's affected his chest as well. So all of those, I think, are possibilities. Okay. And so that's the assessment part of the SBAR, and then the recommendation. I'm really looking for somebody to come and assess him, if that's at all possible, to decide what the next appropriate thing to do is. So hopefully that's helpful for those of you who have never seen that before, as a sort of structure about how to communicate to someone else about what your situation is. So you're probably going to call his family if he has family, aren't you, and let them know what's happening, and potentially also talk to them about what the options are from here. We would hope that he's got some advanced care plans, that we've talked previously about what he might want, whether he wants repeat admissions to hospital, if things were good, where he might want to be. And he's got dementia and cognitive impairment, so he may well not now have capacity to have those discussions. And so we would also want to know if any family are officially lasting powers of attorney for health and whether they can make decisions on his behalf. Okay. So I think we'd like him to be assessed in some way, probably by primary care or his GP. I don't know what everybody who works out in primary care is thinking in terms of assessment, face-to-face, virtual, telephone or proxy assessment through the nursing home staff. I think I've got that as a poll, Charlotte or Jess. Do you mind launching that, and we can see what people think about how they would like him assessed, or how if they're in a position to do the assessing, what they might do. So thank you. That's looking like a reasonably even split between the top three, or face-to-face of 40% of people, 41% would assess him face-to-face. And I think, that would be by far the ideal way to assess him, wouldn't it? It's difficult to get everything through a video consultation, and certainly listening to his chest is not going to be possible through video consultation. I realise he may have COVID, he's got temperature, he's got a cough, and that's one of the high possibilities, and you would need to be careful about the risk and use appropriate PPE. I think most people will have done a telephone assessment by the nursing home staff anyway before they've thought about any further assessment. And from a palliative care point of view, we would be happy to be involved in a patient like this. And certainly if we thought that, he wasn't improving and maybe towards the end of his life, But to be honest, it's likely that we would ask for an assessment from primary care first off, for all of the reasons that you all put on the chat, really, to just put the situation in context and to see whether we did feel that there was a potentially reversible element of this, and to see how we might treat him and where the most appropriate place of care for him was. Thank you very much. Right, I'll close that. Okay, so there may be a potential reversible element to this, mightn't there? If he's got a chest infection, then that, you know, may respond to antibiotics, and he might improve. If he's got cardiac failure, then diuretics may be helpful. If he's got COVID, there probably isn't anything specific you can do other than supportive care, but it's certainly worth considering. To place the situation in a longer context, I guess that means, you know, how has he been over the 15 months? We've talked about him deteriorating generally, losing mobility, swallow being difficult, communication being difficult, and it may be that he's starting to deteriorate in a general way anyway. And that does influence what you might do with the acute situation that's going on at the moment. I think if you'd been the wellest person in your nursing home, zipping up and down the stairs and around the place and going out for long visits with his family, you may be more likely to consider treating him in a slightly more aggressive way. We've also got to consider the situation that we're all in at the moment. It's very difficult in acute hospitals at the moment and potentially risky places to be, so you would want to think carefully before sending anyone there and carefully weigh up the risks and potential benefits. And we've talked previously about any advanced care planning and wishes around his future care. And you can see that if you have got that and you've got it in place, it's incredibly helpful in situations like this. And if you haven't, then this is the time where we're really going to be wishing that we had. Okay. So advanced care planning documentation, and the pieces of paper are not important, the conversations are. And documenting something somewhere that you can refer to is the most important thing. But these are just some of the examples of documentation that's used within our health board. So on the left-hand side there, an advanced care plan for patients who have capacity to make their own decisions. And on the left, the treatment escalation guide for patients who don't have capacity to make their own decisions, but where we can record what we think may be in their best interests, and also record who that has been discussed with and why. So that would include family members who are lasting powers of attorney, for example. And communicating is really important in this situation as all other situations. I don't know how easy it is to communicate with Reg, but we really must try to update him as best we can, reassure him and let him know what's happening. And then we need to communicate with family, don't we? And that's all the more difficult now, because we're dressed like this. Family can't necessarily come in, and it just makes life an awful lot harder. But we've got to do our best with our communication, haven't we? I've shown you a video before about communicating in PPE. I think it probably is worth playing again if I can get it to work. I'm having a little bit of difficulty with this computer, but I will give it a go. If it doesn't work, some of you have seen it previously, and for others of you, it will be embedded in your slides that we will send on.
So we'll talk a little bit today about some of the difficulties that we're all as health professionals going to face during this time of the COVID-19 pandemic. Unfortunately, many of us are going to experience many of our patients who will be elderly and have multiple comorbidities dying during this time. Communication is really important when we're looking after patients who are this sick or who are dying. But we're going to have lots and lots of barriers to communication that are going to make it really difficult. The things that we're going to have to face and get around is going to be wearing PPE, a face mask, a apron, gloves, a visor. All those things make it really difficult to talk to a patient. But there are ways that we can get around these things and still show that we care and that we have compassion for every single person. So the first thing I would suggest is to remember the power of eye-to-eye contact, because we can show that we care by looking at a patient. We can show that we feel connected to them by looking into their eyes. Second thing I would suggest is your tone of voice. If we can keep it gentle and kind, it makes a huge difference to a patient, just speaking slowly and gently. Third thing I would suggest is coming down to their level. If you stand over a patient who's feeling isolated and frightened, it makes them even more so. So just take a chair, sit down next to them, or crouch down. Just to be at their level makes a huge difference. Fourth thing is you can still take their hand even though you're wearing a glove, and have that little bit of physical contact can bring great comfort. Fifth thing, keep language simple. Speak in short sentences and give a chance between things that you're communicating to your patient for silence. Try and be comfortable with that silence, because that's the time when the patient is absorbing what you're saying to them. So overall, if we just take these simple steps, we can make a huge difference to the experience of every single patient at this incredibly difficult time.
Thank you. Bear with me for a second while I get back to our slides. Okay, we're still playing YouTube in the background. Sorry. Talk amongst yourselves for a second. I'm getting there.
I've put some of the links up, so I found a link to SBAR for, in case that's a concept that's new to anybody, on the chat, but I've also found a link to that YouTube video that you've just seen. But if you Google Clear Atkinson communication skills PPE, you'll also find it. But just in case, it's such a simple video, just in case you want to share it with others in your team, that's all in the chat function.
Thank you. Can you hear me okay, Fiona?
Yes, all good.
And thank you. So back to Reg, our 89-year-old who's breathless, got a cough, feels hot and looks really poorly, and you're very worried about him. So what's wrong with him? We've talked about chest infection, aspiration, heart failure, COVID, any or all of the above. Is he dying? Well, he might be, but there might be a reversible element that you might potentially want to treat. Should he be admitted to hospital? I think that's tricky. You've got to wonder how much he would benefit. What would we do for him in hospital? We're not going to take away the fact that he's been generally deteriorating, that he's got heart failure, and each time he's been in, he doesn't really regain his previous function. We know that being in hospital has helped to disorientate him and make him agitated. He wouldn't be able to easily have visitors, and he may well spend 24 hours in an ambulance or on a trolley. I'm not saying admission to hospital is the wrong thing, and only the people that know him well or have taken part in the assessments can really make that decision. But I do think it's something we should think carefully about and consider if that really is the right thing to do for him. Were his dementia and his other serious conditions causing him to deteriorate anyway? I think possibly they were, and I'm going to talk about that in a second. And we've already mentioned what he'd want and what his family want, and are they able to make decisions on his behalf? And if he stays in the nursing home where he is, what do you need to do in order to plan his further care? Okay, so should he be admitted? Actually, at the moment, if you called an ambulance, it would take a long time for it to come. And when it did come, certainly in Wales, where we've done lots of work with the ambulance service, they're not a taxi service, they're healthcare professionals like the rest of us, and so they will come and perform their own assessment. And they may well challenge on should this person be admitted, call the GP back or call someone from palliative care if he's known to us and talk it through. And sometimes we'll come to a different decision not to transport the patient and to take part in trying to set up support where he is. Okay. And again, I think it's really important to share decision making. You shouldn't have to be making these decisions on your own or feel under pressure to make a decision that you're not comfortable with. There are lots of people as part of the wider teams that you should be able to contact. In Cardiff and Vale, CAB 24/7 means that you can still call an ambulance and be transported to hospital, of course, but in general, patients can't pitch up at A&E anymore. They need to phone, go through telephone triage, and if it's still appropriate to go to hospital, will be given an appointment. So things have changed a little bit, hopefully for the better, and perhaps driven by the pandemic. So of all those things that he may have, we've talked about sharing the decision making. It might well be appropriate to try and give some antibiotics orally and keep him hydrated. It might well be appropriate to increase diuretics if you think that this is heart failure, but the temperature would be against that, and you obviously wouldn't want to be drying him out further if you thought that he had a chest infection. It might well be appropriate to get some further speech and language assessment if we think his swallow is difficult, because there might be some simple things that you can do, as you know, with thickeners or just the ways in which we feed people and how we help them to try and swallow as best they can. And even if there is no specific treatment for something that's happened, like an aspiration or whether he's got COVID, sometimes people do recover. We've had very sick patients in the hospice who've had COVID and have really surprised us and got better. It doesn't need to be one thing or another. It doesn't need to be active treatment or dying. It could be a bit of both, if that makes sense. We can treat an infection with oral antibiotics if he's able to swallow them, but also be prepared to manage end-of-life care if he's not responding. So we can be sort of hoping for the best and planning for the worst, if you like, and doing both things or bearing both things in mind. How do we diagnose dying? It is tricky. I've shown you that bit of graph before. It's hard, but those people who know him best are going to be the best place to try to say. And I've been to lots of nursing homes where I've seen patients and I'm really not sure, but often the staff are incredibly helpful in saying, well, he's changed dramatically in the last 2 weeks, or we've known him for a long time and he's not usually like this. He's getting worse by the day and we're really concerned. People who are bedbound, only able to take sips of fluid, struggling with their tablets, and are very sleepy and maybe semi-comatose, then they're possible indicators that we're in the last few days. So I think his dementia and other serious conditions probably are causing him to deteriorate anyway. I know that you can't see that, but the disease-specific indicators there under heart disease is talking about increasing breathlessness, lots of admissions to hospital, and under dementia there it's talking about decline in mobility, ability to dress, ability to communicate meaningfully, and that would all suggest that things are progressing. And as you know, we use if deteriorating month by month, then the prognosis is likely to be months. But if actually he's deteriorating each day, then it may well be that his prognosis is in terms of days, and that allows you to give his family fair warning and him, if that's appropriate, and to plan appropriate things. So if he's dying and he's going to stay in the nursing home, I'm sure you would keep him and his family as informed as you could. And I'm sure you don't need me to tell you things like to consider privacy, dignity, cultural, spiritual and religious needs. We'd need to control his symptoms and stop doing things that weren't necessary, like OBS and giving him unnecessary medicines. And we'd want to make sure that if we were expecting him to pass away in the nursing home, we had, if he didn't already, a DNA CPR form signed. So that's the care decisions guide for the last years of life. Used to be the old care pathway. We used to use it quite a lot in certainly in the Cardiff and Vale area, and we've sort of stopped using it a bit recently. Part of that's a good thing because we're now much better at managing dying, and we know we need anticipatory medicines, and we know that we need to get a DNA CPR form and inform family. But there's loads of useful guidance on there and reminders of what we should be doing. I think it would be helpful to adopt the documentation again. It's all been revamped, it's now new and takes into account all of the latest considerations. And I think certainly in the area where I work, we'd be looking to try to reintroduce it and see how we could use it in a useful way for patients and staff. So DNA CPR forms, very familiar with these, I'm sure. I've shown this slide before as well, but I'm just highlighting that sometimes things happen unexpectedly and there's no form. And if, as a healthcare professional, you think that CPR is clearly inappropriate, for example, if it was obvious that someone was dying, or actually, if you're in a situation where you've discovered somebody who has died, then you should be able to make a considered decision not to start CPR, and that really ought to be supported by senior colleagues, employers and professional bodies. And that's a direct quote from this document, which is Decisions Relating to CPR, jointly published by the BMA Resuscitation Council and the Royal College of Nursing. Okay. You don't need me because I'm a doctor to tell you about good nursing care, but it's just worth considering pressure relief, turning, appropriate beds, mattresses, equipment, mouth care, and food and fluids. People who are dying don't tend to need or want or are able to take in lots orally, but that causes lots of distress to family, as you know, and it's worth going over that and explaining carefully to people. And obviously if people are able to take sips of fluid or small amounts of soft food and it doesn't appear to be distressing them or going down the wrong way, then we would continue where we felt that was the right thing to do. So anticipatory medicines, we've done lots about these for things like pain, breathlessness, agitation, delirium, nausea and vomiting, respiratory secretions. So in the area where we're working, they get prescribed on a community drug chart there by a prescriber. And then there are certain COVID type strategies in place at the moment. We've talked about this before, the GEMP scheme, where you can get medicines pretty quickly within 2 hours, 24/7, if you go through the appropriate procedure. And all of the prescribers in the area should have received information about this and should know how to do it if they need to. And there's a link there that gives you all sorts of information about that service. Okay, there is, in the midst of a pandemic, if we're running short of medicines, there is local guidance in place about repurposing medicines that you have already. So they might be medicines that have been prescribed for someone else who no longer needs them because they've passed away, or no longer needs them because they're now on different medicines, or actually doesn't need all of them right now and they've got quite a lot of stuff already. There is guidance in place where you could use that medicine for somebody else, as long as it's prescribed on a medicine chart. If you've got the medicine in the care home, then that might well be able to be used while you're trying to source stuff from pharmacy for the patient who needs it as a new person. And if it really comes down to it, and we are in a very difficult situation with medicine shortages, there is also guidance in place about sharing ampules. So if you've only got one vial of midazolam in the care home and 2 patients who need it, and they only need a half or a quarter of a dose each, and that's all they're prescribed for, then there is guidance in place about how you can sort of draw half of that medicine for one person and half for the other. But it would be really, really important to follow the guidance very carefully and make sure that we're doing that in a safe way. And I'm just very quickly going to go over some of the common symptoms, and we've done this before as well, so I'll go quickly. Breathlessness, very common. Breathing techniques, reassurance and opening the windows can be as helpful as any drugs. In normal circumstances, we'd think about fans, but we'd probably want to avoid those if we were suspicious of COVID. Morphine's the main thing that we might use for breathlessness, and midazolam if people are very anxious and panicky. And oxygen's unlikely to be helpful unless patients are very hypoxic. You may well not know that if they're in a care home. And even then, it's often a barrier, and reassuring patients and giving them appropriate medicines is likely to be more helpful. Okay, pain is common in dying of any cause, although I haven't talked about it as a particular problem for Reg, and we would tend to use morphine subcutaneously as a first-line opioid, and you've probably seen things like oxycodone also used. If patients are requiring several subcut medicines, then we'd think about a syringe driver, and if they're on patches, we tend to leave those on and add medicines either via injection or a syringe driver if needed. So restlessness and terminal agitation, look for fixable things like urinary retention or fecal impaction. And delirium is common in things like UTIs, so you'd want to be sure that it was terminal agitation that you were treating. And if people are dying and restless, we often use medicines like midazolam or levomepromazine. Nausea and vomiting. If it's not been a problem so far, then we would hope it wouldn't be a problem towards the end of life. But sometimes if people are having certain things like morphine for the first time, they may feel sick and may be sick. And things like metoclopramide, cyclizine or levomepromazine are subcutaneous medicines that we might use. And those of you who've lots of experience in nursing and in care homes have probably heard lots of people get very rattly or noisy breathing towards the end of their life. It can be distressing for family and for staff. Patients are often unresponsive and not looking like they're particularly distressed themselves. And it's often just a pooling of saliva in the back of their throat. But sitting them more upright or over on their side can be helpful. And we do use medicines, although actually there's no evidence that they're particularly effective. But we use things like hyoscine, glycopyrronium, and sometimes buscopan. The most difficult thing about managing patients dying in nursing homes is, would you mind launching the poll for me, Jess or Charlotte? And the reason for this poll is because we asked this exact same question talking about patients who are dying at home. And I think it would be interesting to compare the results, really. Thank you. So discussing difficult issues is coming out top at the moment, things like DNA CPR, especially over the phone, I'm thinking, especially if it hasn't been brought up previously and we're now in a crisis. So organising care is much lower there than it has been in the community and for people who are at home. And that's the great advantage of being in a nursing home, isn't it? You've got people there to look after you. That's why people are there. And so however difficult it might be caring for people who are dying in nursing homes, you've actually dealt with one of the major problems that we have when people are at home, in that there's care available and on hand. So the communication issues are by far the highest there, and then it's managing medicines and syringe drivers and things, and then sometimes equipment and sometimes accessing advice from other services. Thank you. Just close that. Okay, so that was a bit of a whistle-stop tour. Thank you. I'm hoping I have still got lots of my audience and panel members on the chat there. So how can we support nursing homes better? Put your thoughts onto the chat there. And whilst you're doing that, I'm going to see if we have still got Emma Watkins out there in the audience, who's one of the senior nurses in one of our local care homes, who, if we can, was just going to give us a couple of minutes of her thoughts on how we can support nursing homes better. Are you there, Emma? Come in.
You just want to unmute your, just undo your video. I'm not sure if everyone can hear me.
Yeah, I can hear you. Meantime, Fiona, have we got some interesting stuff in the chat?
Yes, we've got. I'll say afterwards.
No, you crack on.
Go on, Emma. We can hear you now.
I've unmuted Lizzie's as well, so she'll be able to see, because we both dealt with a lot of palliative end of life, and we found it definitely more difficult as COVID's hit, which obviously it can't be helped. But for us, we found it more difficult when we've had newly diagnosed residents come to us for palliative care, and they're struggling with the decisions themselves as well as we are. So it's difficult, I find, to help support them, but also like we had a patient last who was with us, and he had capacity, so we were cut out from a lot of his palliative care support, and it was going straight to him, but he didn't quite fully understand what was happening. So like palliative teams are ringing him directly, and then he'd be like, oh no, I don't need that, and then with us he's telling he can't breathe, he can't cope, he's severely depressed. And I just found it was very difficult for the staff on that floor, and very stressful to deal with, because we were kind of like cut out but expected to deliver all his care. And I find that's happened a few times now since COVID's happened with us, where we're just giving patients who are brand new diagnosed and not fully supported.
Okay. And I guess that's the difference, isn't it? Because we'd normally be there face to face, and then we'd automatically be able to talk to you as well as patients and potentially family. Yeah. Okay. And are there any other ways you can think of where you could be better supported, Emma, do you think?
I'll do something else. Because Lizzie dealt with my more than I did. It's really hard.
Liz,
yeah.
Did you want to come in?
Only that I recognise some of the scenarios that Emma was just discussing regarding the patient and talking to him and eliminating you in palliative care, which wasn't the reason, but he did have capacity and we did speak directly to him. Only that how we address that now, and obviously when I did speak to him out in the conservatory or outside, and you were present during that consultation, it was a much better assessment. So how we approach that to include you as well during the palliative care assessments, really, is obviously taking into consideration the patient's wishes as well.
And I guess it's just another way we're all trying to adapt, aren't we?
Yeah.
Yeah. Okay. Thank you. Did you have anything else to add, Emma and Lizzie?
It's just been really hard with COVID, and I know it's really difficult for everyone. It's just that because we're not specialists, and I know you've said in your PowerPoint that a lot of non-specialists look after them, it's just been really hard trying to support the residents, support the families also, and tackling those really, really difficult conversations, because they want support from us, and that is our job, to support the residents and the family. But it's just been so hard when COVID's here, they can't visit their loved ones. We're trying to liaise with yourselves, you can't visit, we're doing everything over virtual, which isn't always working very well. It's just trying to tackle those conversations so we can support the family, support the residents, and so I can support my staff. Because also when we had that resident in, and it was really hard for him, but I also have to take into account how it's really difficult for my care staff that are looking after him as well.
Yeah. And do you think more sessions, I know Liz has been talking about education and things, do you think that would be helpful as well? I know you want us to support you to have some of these conversations with individual patients and families, and that's absolutely fine, but do you think some more teaching about things like communication skills and more of the palliative care stuff would be useful?
Definitely, with the care staff and the nurses, because we are their first port of contact, because they come to us and then we liaise with everyone else. So, and we're that person that they speak to first, depending on your type of relationship. With that patient that we discussed earlier, I had a really good relationship with him, but it was hard. But it took a very, very long time to get that rapport. And because of the time frame that we were in, we didn't have a lot of time. And it was really, really difficult for him to be able to trust me, and for me to be able then to do my best to help him, because of how difficult the situation was. I felt like I failed him as a person, even though I know I never, and I know I worked really hard
to get
him what he needed. It's just that I was that person to try and hold it together. And it was just really, really difficult for me to support him, to support his family, to support my care staff, to liaise with everyone else, GP, yourselves, and etc. And it was really difficult for me and the nurse that worked alongside me on that floor during that time.
Okay. And I guess, the whole COVID thing, you've not only got to be a nurse and advocate for all of these patients, but you've almost got to be you've almost got to be their family as well, haven't you? Because they can't come and visit and be as involved as they might have been. And I'm sure that that's really tricky. But we'll come back to you, Emma, on exactly what we can do to be more supportive and on the educational side. Is that okay?
Yeah, that's absolutely fine. Yes.
Thank you. Okay, so yeah, the pandemic, you know, you don't need me to tell you this, but the issues of an outbreaks, PPE, visiting, reduced face-to-face support from other people, staffing and sickness, and I think what Emma's describing is just emotional exhaustion for the whole thing, isn't it? And I think, you know, these are some of the things that I think might be helpful. And we haven't really talked about residential homes, which I'm sure has lots of similarities, but actually not the same sort of qualified nursing input, and their issues are going to be different, and sometimes worse, and sometimes, you know, sometimes just different. So it's about how we can best support you. So some of the people who are trying to provide some support, I know, have been our advanced care planning facilitators, and I know that they've been in touch. And if you're out there, Alex,
I am.
And bring you in to talk about your initiative. I'll put your slide up, that's all right.
Hi everyone. Yeah, my name's Alex James, and I'm one half of the Advanced Future Care Planning team. I think my colleague is in the audience there somewhere, Karen Smith. So prior to COVID hitting, we were going out and providing face-to-face training for everybody, and we've both unfortunately been redeployed for best part of between April and November, but now we're back in post and sort of keen to get going. So as we've worked with College Fields, and I know Lizzie and Liz and Emma there very well, so hi both. The overall aim of this project was to provide everybody, all the different clinical areas across Cardiff and Vale, with education and support to do advanced care planning, so their patients, so all our patients had an equitable sort of opportunity to get involved in these conversations. Clearly, sort of at the moment now, because we can't do our face-to-face training, we've tried to develop the Champions program in a digital sort of format, so that we can, you know, do like this through Zoom and sort of support you that way. It sort of falls into two things really: the work-based teaching and raising the profile. So these two things, we know that sort of, you know, from what we've done before, just helps more patients to access, you know, the advanced future care planning if they want to do so. Can I turn the slide, or would you do that, Joe? Thank you. So essentially, sort of, we've got three sort of parts to this: raising the profile, reflection, and teaching. Now, this is sort of very flexible. This is just gives us a framework to work from. We think it's really important for all you nursing homes, you know, the areas, to think about how we can help you with advanced care planning in your areas, and what sort of problems that you've been encountering, particularly sort of now with COVID. And that way sort of we can try and sort of focus in on the things that you know, that we can support you with. But sort of, we think it's also very important to be interactive with this, and for you to try and think about, and I know that Lizzie has done some of this already with me, but raising the profile of advanced care planning in the different areas through a poster, an information point, could be through a cafe, or through all sorts of different things, and actually sort of just to sustain it. Because once we come in and we do our training, or we train our trainers, then we're gone. It's how sort of you're going to keep that alive, you know, and sustain it in the long term. Then reflection, we all sort of learn from, you know, reflecting on our experiences, and actually sharing that sort of, it can be really valuable. So our case studies and our patient stories, that we're very keen to sort of work with those kind of things, because that makes it much more relevant, you know, to you and things that you're experiencing. The last thing, sort of the part of the Champions program, is the teaching. And you know, our job is, our project finishes in September 2021. So we need sort of at that point that anybody who's interested in joining this program, you know, is confident, sort of, and competent to teach their colleagues the key principles of advanced care planning, and actually sort of to guide them and support them going forward. So we would like sort of, you know, for them to just carry out a short teaching session. We'll provide the PowerPoint, and then, you know, to actually sort of talk them through that, so that they feel confident doing so going forward. So, you know, we know that sort of embedding and sustaining advanced care planning is actually quite difficult, but it's really, really important, because otherwise only a snapshot of patients will get the support and the, you know, from us being in role. So if you would like to be involved, I would perhaps Karen put our emails in the chat, and you can get in touch with us. You know, we're happy to talk to you sort of and to try and make it work for you, because we know sort of how hard it is for everybody at the moment with all the other sort of pressures that you've got going on. And that's it, really. Thank you.
Thanks, Alex. And I think I'm going to leave it there and take any questions that we've got, or if anyone would like to put any further questions in the chat, please do. I've got one last slide, which is something called 6 Steps, which I don't know very much about, but I do know that health boards elsewhere in Wales use it, and it's a programme teaching for care home staff. And I know that Cardiff and Vale are potentially going to look at it to try and make a little bit more uniform what we're all teaching, rather than us sort of doing our own little thing. But I'm sure it will, you know, looking at the titles there, it just covers lots of the things that we would have covered anyway: the last days of life, advanced care planning, and how to coordinate care. So are there any questions either for me or for any of the other people that you have heard from?
There's a question, there are a couple of points. There's a question about oral care, and there's a question about oxygen. So should we take the oral care first? And it was just really, is there anything sort of specific about oral care at the end of life? Any top tips?
Do any of my nursing colleagues want to take that, Liz or Alex? Or shall I? Thank you, Liz.
I think it's just basic nursing care, really. At the end of life, obviously, they used to use one of those sponges for cleaning the oral cavity, but now we say to use a baby brush, just even baby toothbrushes with the toothpaste, and just be gentle. Frequent fluids, just ensure that it isn't infected, they don't have any oral thrush. And obviously it's quite a simple solution to the treatment for oral candida. I think it's just basic nursing care, really. And don't be frightened, even if the patient is unresponsive. Don't be frightened of them, and and just treat them as if they were conscious. Just be careful that they don't aspirate any of the oral solutions. We tend not to use the oral mouthwashes that they use, because it's quite strong with the alcohol in it. But just as I said, a small amount of bicarb is sometimes quite good if they got coatings on their tongue. But gentle nursing care, really, and just basic nursing care, what we used to do years and years ago, really, and don't be frightened.
Thanks, Liz. So what you're saying is there's any number of medicines and things out there, aren't there, and artificial sprays and salivas and gels and stuff, but actually lots of it's your basic nursing care, I think, is what you're saying.
And I sometimes find that the patients who are quite conscious and respond to us say that the sprays, they're quite ruthless, because when they do spray it in the mouth, they quite gag on the spray. So, using that on somebody who is semi-conscious or is actually dying is not one of the best things to use, really. And if they are conscious and they are eating certain things, sometimes we just advise some pineapple, some juices, some ice lollies. Even if they're not able to take the Fruzabin or the Ensure, sometimes we advise them to make up some ice cubes in them, and they can suck that up to get some hydration into their mouths as well.
Thanks, Liz. Thank you.
There was another question around domiciliary oxygen. Yes, thanks, Liz. Just in terms of, actually it can, as somebody very experienced has just said, actually it can be as useful as the diamorphine. And is there a role for it in terms of anticipatory medicines? So just opening up that conversation around how useful is it, and is there a way that it can be kind of, how to manage domiciliary oxygen? Be really interested in people's thoughts on that. What do you think, Jo?
Yeah, and I guess people can put their thoughts on the chat as we're talking. Yeah, I wouldn't discount oxygen. If people are significantly hypoxic, then oxygen can be got in nursing homes, as you all know. I suppose I was just saying I didn't want it to be seen as a panacea for breathlessness, really. And it can cause a barrier and another thing that you have to manage. But yes, for people that are significantly hypoxic, it may be worth considering, along with all of the other things, the sort of reassurance and the non-drug measures, and then, you know, things like morphine and potentially some midazolam for panic. So yeah, I wasn't discounting it, but wouldn't want it to be a sort of knee-jerk or breathless, must need oxygen type approach. Does that make sense? Did you want to add anything, Fiona, or have we got anything else on the chat?
No, that's kind of where I was thinking as well. I think there's the practical. So Colette, you've added things on the chat, and thinking just sort of how to access it, through which team would a nursing home access it, or would it be through the GP? And that might differ slightly where you are across the country. So just thinking, Jo, just for locally, what would happen if?
So where I work, which is in the Vale of Glamorgan, it would be via the GP, and the way to do that is all on the Cardiff Vale intranet on the primary care pages, which talks GPs who haven't done it very often or are not very familiar with it, talks them through what they need to do, the forms you need to fill in, and the numbers to ring and that sort of stuff. And I guess the chronic respiratory teams, the crew teams, which are based at Llandoch for those of us who are local, are also able to talk that through with people.
There's a really interesting comment from Tyne around, do we have community care paramedics within our 999 service? So Tyne, I'm sort of guessing that you you may not be working locally, but I could be wrong, forgive me if I'm wrong, but community care paramedics sound really interesting. We've got particular paramedic service in Wales, and Jo says that we've been doing a lot of work with over the last years, really getting palliative care around and really getting some good collaborations. So Jo, I don't know whether you want to say a little bit more about
I think there are paramedics who work with the out of hours triaging service. I'm not quite sure whether they visit patients. I'm sure that they do, and you know, paramedics are one of those groups of people who are very comfortable with going to completely unpredictable situations in the community. There are also a couple of paramedics that I know of that are working within GP practices as part of the primary care team, and are doing the same sort of thing, you know, triaging patients and going out to do community visits. And some of them, I think, are now prescribers, or certainly on the way to becoming prescribers.
And we've got the answer on the chat, so thank you, Tyne. Tyne is a community care paramedic in Canada, so you have been very welcome, and I can't even begin to think what time it is where you're working. I think that message, Jo, that's really important, isn't it? We've done a lot of work in Wales with our local ambulance service. I'm sure if you're joining from outside of Wales, I'm sure that you probably are too, but if you aren't, then now's the time to get going and get talking and get working together.
If there's no other burning questions, I can't see them, but we're a few minutes over. Should we leave it there? Do you think those of you who can see the Q's and A's in the chat?
Yeah, I think that would be great, Jo. It's just left to me to say thank you so much for today's speakers, for all of our panelists who've contributed, also to all our attendees. As Charlotte mentioned, it is the last webinar in the series, and I'm sure Jo and Fiona would agree we've had some fantastic numbers throughout the series, so it's really great to see so many people here. So we're really grateful for that, so thank you. Just to say, we will be sending out a feedback questionnaire probably tomorrow afternoon. We would be really grateful if you could just take a few moments to complete that for us. Having that kind of feedback is what allows us to put these type of events on, so that would be fantastic. And I know that Charlotte also wanted me to mention that it's probably a good idea to keep your eye out on our social media channels, because we're going to be running some community oncology webinars in the new year. So keep an eye out for those. If you haven't already signed up to receive our newsletter, then there will be an opportunity to do so when I send out the surveys. So you can also kind of keep up to date with things like that. So other than that, thank you very much. Thank you, Jo. Thank you, Fiona. And thank you to all the other panelists. And thanks to everyone for attending.
Thank you to the panelists. Thanks to everyone. There's a quick question saying, will the slides be available? So you've just said that you were going to send the slides, Jess, haven't you?
Yes, that's correct. Yeah, we'll be sharing the slides with everyone.
Okay, well, thank you to everyone.
Thank you.
Bye-bye.